Hello everyone, I am Dr. Rajeshri Chandar from med-medha.com and our today's topic of discussion is the oculomotor nerve or the third cranial nerve. Now this is a very important nerve for your theory questions because it comes as a long question. Now when we are describing each cranial nerve, we will start with what type of nerve it is. So this oculomotor nerve is a purely motor nerve along with the fourth nerve, that is the trochlear nerve, the sixth nerve, that is the abducent nerve, and the 12th nerve, that is the hypoglossal nerve. Next we will study about the topic that is the functional component of the oculomotor nerve. Now since it is a purely motor nerve and we know that in the functional components there are three types of motor functional components. One is the somatic efferent, which supplies the muscles which are derived from the somites. One is the branchial efferent or the special visceral efferents, which supplies the muscles derived from the branchial arches, and another is the general visceral efferent, which is the preganglionic parasympathetic fibers, which supplies either mainly in majority of the places the glands, but here in case of oculomotor nerve it supplies two muscles. So let us move on to studying what are the functional components of this oculomotor nerve. So it is a purely motor nerve. It has got two types of functional motor components. One marked in yellow, you can see the somatic efferent, and the one marked in green, that is the general visceral efferent. Now if we see the somatic efferent, you can see it can supply a number of muscles. These are the extraocular muscles, and the general visceral efferent, you can see that it is relaying into a ganglion, which is a parasympathetic ganglion, which is the ciliary ganglion in this case. Okay. So this is a ciliary ganglion in this case, and this fiber acts as a preganglionic parasympathetic fibers because it will relay or synapse in the ganglion. Now the postganglionic fiber in this case, you can see it forms a number of nerves which are known as the short ciliary nerve, and it comes out. Now regarding the somatic efferent, they will supply the extraocular muscles. As we know that there are 6 extraocular muscles, of which there are 4 recti and there are 2 oblique muscles. So what formula does this extraocular muscle follow? It follows 3LR6SO4. So 3 stands for the oculomotor nerve. So that means all extraocular muscles are supplied by the oculomotor nerve except 2 muscles. One is the LR, which is the lateral rectus, which is supplied by the 6th nerve, and one is the SO, that is a superior oblique, which is supplied by the 4th cranial nerve. So this is the formula that you have to remember when you need to study about the 3rd, 4th, 6th nerve as well as the extraocular muscles. Now what about this short ciliary nerve, which is basically carrying the general visceral efferent fibers? This short ciliary nerve, I said in it will supply 2 muscles in case of oculomotor nerve. And what are the muscles? One muscle is the sphincter pupillae muscle, which is responsible for the constriction of the pupil, and the second muscle is the ciliaris muscle, which will help in changing the convexity of the lens, thereby it helps in accommodation. So this is about the functional components. Now the next heading that we need to study any cranial nerve is what is the deep origin, that is the nucleus. So deep origin because it is deep within the brain stem. Now oculomotor nerve, it arises from the midbrain, and in the midbrain you have seen in the dorsal aspect of the midbrain there is the corpora quadrigemina, which is formed by a pair of superior colliculus and a pair of inferior colliculus. The nuclei of this oculomotor nerve arises in the level of the superior colliculus, and where from? Now within this midbrain there is a cavity which is known as the periaqueduct of Sylvius, and surrounding this cavity there is presence of a grey matter sheet which is known as the periaqueductal grey matter. Now if you see in the ventral aspect of this periaqueductal grey matter, there is the origin of the oculomotor nerve in the form of the oculomotor nuclear complex. So there is a complex of nuclei present there. So what is the deep origin of this nerve? So it arises from the ventromedial part of the periaqueductal grey matter at the level of the superior colliculus of the midbrain. So this is exactly how you have to write. Now after taking origin from here, the grey matter, the axon of the nerve fibers, it passes through the substance of the brain, midbrain, from the dorsal aspect to the ventral aspect, and you can see it is coming out from the medial side of this structure. This is the cerebral peduncle or the crus cerebri, and it comes out from the medial side of that crus cerebri. So, that when you are seeing from the surface of the midbrain, the nerve where you are seeing, that is known as the superficial origin. So, after deep origin, next we will study about where lies the superficial origin. Now, the left hand side picture that you can see, that is the picture of the ventral aspect of the brain stem, with the midbrain above, the pons in the middle, and this part is the medulla oblongata. Now, in the midbrain portion, the portion that you can see on either side, this marked, that is the crus cerebri or the basis pedunculi. And on the medial side of that basis pedunculi, you can see coming out is one cranial nerve, and from the lateral aspect is coming out another cranial nerve. This cranial nerve, which is coming out from the medial side of the crus cerebri, that is the superficial origin of the oculomotor nerve. So, that is where we have to identify the nerve when you are given a specimen of the brain stem or the specimen of the entire whole brain. So, here we have already seen that it is coming out from the medial side of this crus cerebri, and the same thing you can see on in this picture, it is coming out from the medial side of the crus cerebri. So, what is the superficial origin? So, superficial origin comes out from the medial side of the crus cerebri of the midbrain, again at the level of the superior colliculus. So, when you are asked, if this is how you have to answer. Now, after it comes out, next it has to go and finally terminate into the branches, and that we call as the course of the nerve. So, course of the nerve, when we are writing, we have to write in the form of the flow chart. So, first let me describe it, then we will tell how you are going to write it. So, course. So, once it comes out from the medial side of the crus cerebri on the surface of the brain, there this oculomotor nerve lies between two arteries. Now, here in this picture, you can see this arterial circle of Willis, right, and this is the section of the midbrain, this part is the section of the pons, and this part is a section of the medulla, which I had showed you earlier. Now, you can see in the ventral aspect of this pons, there is an artery. This artery is a basilar artery. This basilar artery, when it goes to the upper border of the pons, that means near the lower part of the midbrain, it bifurcates into two arteries. These are the two posterior cerebral artery, and the penultimate branch of this basilar artery on either side, you can see these are the superior cerebellar arteries. Now, if you can see that between this posterior cerebral artery and the superior cerebellar artery, you can see two nerves coming out on either side. The one that is on the medial side, that is the oculomotor nerve. So, the first relation in the course of the oculomotor nerve that you have to remember is that after it comes out from the medial side of the crus cerebri, it lies between the posterior cerebral artery and the superior cerebellar arteries. Now, next, what is the relation? Next relation is also a vascular relation. Now, we know that this posterior cerebral artery, in order to complete the circle of Willis, it connects with the internal carotid artery through a branch of the internal carotid artery, which is the posterior communicating artery. Now, if you can see this oculomotor nerve lies on the lateral side of that posterior communicating artery. So, that would be the second vascular relation. So, first it is lying between two arteries, then it lies on the lateral side of the posterior communicating artery. Now, next, here in this picture you can see the base of the skull with a dural sheet. This dural sheet that you can see, this side has been cut out, but the other side you can see, this dural sheet is the tentorium cerebelli. Okay. And this tentorium cerebelli has got two margins. This outer margin, which is attached along the occipital bone posteriorly, and the pectoris part of the temporal bone on the lateral aspect, and it extends anteriorly up to this elevation here, which is the dorsum celli, the lateral aspect of the dorsum celli. There is presence of a process which is known as the posterior clinoid process. So, this margin that I am tracing, this margin of the tentorium cerebelli is known as the attached margin, and the anterior most end of this attached margin extends up to the posterior clinoid process. Okay. So, this part is the posterior clinoid process. Now, the other margin that you can see in the midline, on the other side it has been broken. This part is forming a U-shaped notch here, which is a tentorial notch through which the midbrain, pons and medulla passes, and this is known as the free margin. Now, this free margin anteriorly, if you can see, it crosses the attached margin, and the anterior most end of the free margin goes up to this process, which is a portion from this lesser wing of the sphenoid. This is known as the anterior clinoid process. So, in this process, the attached margin lies below and the free margin will cross on top of it to reach the anterior clinoid process. So, this is attached to the posterior clinoid process and this is attached to the anterior clinoid process. So, if you can see my two fingers here, where there is a crossing, there is a triangular area formed there. So, that triangular area which is formed here between the free and the attached margin, there the dura mater forms a triangular area which is known as the oculomotor trigon. Now, why I am talking about dura mater right now? The roof of this oculomotor trigon, which is between the free and attached margin of the tentorium cerebelli, is pierced by the oculomotor nerve. So, in this is a zoomed picture of the oculomotor trigon. So, you can see this is the oculomotor trigon, which is between this attached margin here, and below that this is the free margin here and this is the attached margin. So, this blue outline that have come up, that is the oculomotor trigon, and you can see that the nerve is piercing here the roof of that oculomotor trigon, and that is the oculomotor nerve. So, that is the next relation that you have to remember, that once it goes towards the sphenoid bone there, it pierces the dura at the roof of the oculomotor trigon. Now, once it pierces the oculomotor trigon, then what happens? Now, here just this region is the sella tarsica, and on either side of the sella tarsica here in the sphenoid bone lies a very important venous sinus, and that is the cavernous sinus. After piercing the roof of this oculomotor trigon, this oculomotor nerve that you can see, after it pierces, it lies along the lateral wall of this cavernous sinus. So, that is a very important relation again. So, here this is the sella tarsica in the middle you can see, and on either side these are the two cavernous sinus. Now, you can see in the lateral wall of the cavernous sinus, above downwards there are four nerves passing, the upper one being the oculomotor nerve, and below that it is related to the trochlear nerve, the ophthalmic division and the maxillary division of the trigeminal nerve. So, these four nerves, they accompany along the lateral wall of the cavernous sinus. So, that is the relation. Now, as this oculomotor nerve is passing along the lateral wall of the cavernous sinus and going anteriorly, because it has to come to the orbit, in the anterior part of the cavernous sinus, this oculomotor nerve divides into two divisions. There is one superior rami and there is one inferior rami. And this two rami will then pass out from the cavernous sinus, and in order to enter the orbit, they entered through a fissure which is known as the superior orbital fissure. So, if you see the skull, within the skull there is a V-shaped two openings within the orbit. The upper opening is known as the superior orbital fissure, the lower opening is called the inferior orbital fissure. Now, this superior orbital fissure is again divided into three parts, and what structure divides it into the three parts? This structure. What is this structure? This is an annular ring which is formed due to the attachment of the four recti muscle of the eyeball. So, we know there are four recti muscle, one superior rectus, one inferior rectus, one medial rectus and one lateral rectus. These four recti muscle, on the one end it is attached to the eyeball, the other end, in order to take origin, it is attached to a annular ring. It is known as annular ring of Zinn. this is this annular ring, and this annular ring divides the superior orbital fissure into 3 compartments. So, within the fissure of the ring would be the intermediate compartment, and on the other hand there are 2 more compartments. There is one lateral compartment and there is one medial compartment. Okay. So, this is the lateral compartment, this is the medial compartment. So, the oculomotor nerve, in order to go to the eyeball, now it is no longer a single nerve, there are 2 rami, one superior rami, one inferior rami. They pass through this ring, that is the intermediate compartment, in the form of the 2 rami. So, here you can see both are marked as 3. So, the upper one is the superior rami, the lower one is the inferior rami, and if you see in between, there is one more nerve passing in between these two, that is the nasociliary nerve, and there is one more nerve passing through this intermediate compartment, that is the abducens nerve. So, the superior orbital fissure intermediate compartment actually contains 4 rami, 4 branches. There are 2 rami of the oculomotor nerve, in between that you have the nasociliary nerve and you also have the abducens nerve. So, these are the nerves that enter through the intermediate compartment. Now, so that is more or less about the course. Now, once let us summarize and then we will move on to the distribution. So, this is in gist the entire course. So, here when we start from the lower bottom of the picture, here you can see in the periaqueductal grey matter ventral aspect, this is the oculomotor nerve nuclei. From there the nerve is passing forward, and when it is passing forward at the level of the superior colliculus, there is one more very important nuclei here, that is the red nuclei. So, it passes basically near or through the red nuclei, and then it comes out from the medial side of the crus cerebri. Once it comes out, it is lying between the 2 arteries. Here you can see one is the posterior cerebral artery, another is the superior cerebellar artery, and this posterior cerebral artery is also connected by means of the posterior communicating artery. So, the oculomotor nerve lies lateral to that. Then it is entering into the cavernous sinus, where it is divided into the 2 rami. Then this is the superior orbital fissure, it will pass through the intermediate compartment to reach the eyeball. So, this is the entire course. Now, how do you write it? So, you write it again in a flowchart form. So, first you have the origin. So, it arises from the ventromedial part of the periaqueductal grey matter of the midbrain at the level of the superior colliculus. Next is the superficial origin, that is, it is coming out from the medial side of the crus cerebri. Then finally the course. So, first important relation that you need to remember is the 2 arteries. So, you have posterior cerebral and the superior cerebellar arteries. Next, it passes lateral to the posterior communicating artery. Then it pierces the dura mater of the oculomotor trigone to enter into the lateral wall of the cavernous sinus, where it is related below to the 4th nerve, the ophthalmic and the maxillary nerves. Then within this anterior part of the cavernous sinus only, it divides into the 2 rami, one is the superior rami, another is the inferior rami. And these rami now enter through this annular ring of the 4 recti muscle and are related with the nasociliary nerve in between and also with the abducens nerve. Finally, it will go to the eyeball to supply the extraocular muscles. So, this is about the course. Now, let us see the distribution, that means what muscles are supplied by the oculomotor nerve and which division. Before we go that, this is a picture of the eyeball where I have shown all the 6 extraocular muscles. So, you have the 4 recti, the superior rectus, the inferior rectus, the medial rectus and the lateral rectus, and you can see the 2 oblique muscles. So, this is the superior oblique muscle, this is the inferior oblique muscle. Now, let us move on to the distribution. Now, in this picture, we have described the 2 components of the distribution separately. So, first of all, the component that is marked in red is the somatic efferent component, which will supply the extraocular muscles. So, these are the 2 rami. So, this is the superior ramus, this is the inferior ramus. If you see the superior ramus after it enters the orbit, it divides into 2 branches to supply the superior rectus muscle, which is an extraocular muscle, and it supplies another muscle which is not an extraocular muscle, but it is a muscle of the lid, upper lid, that is the levator palpebrae superioris. So, superior rami of the oculomotor nerve supplies the levator palpebrae superioris and the superior rectus. Now, coming to the inferior ramus. Now, this inferior ramus will supply the medial rectus muscle, the inferior rectus muscle, and it supplies the inferior oblique muscle. Now, this nerve to inferior oblique is very important. Why? Because while it is going to supply the inferior oblique, along with it traverses the general visceral efferent component. So, the general visceral efferent component, I told you in the first slide that it goes and relays onto the ciliary ganglion. It acts as a preganglionic parasympathetic fiber, but in order to reach the ciliary ganglion, it traverses the nerve to inferior oblique. So, see, it is marked together. So, along with the nerve to inferior oblique, this general visceral efferent preganglionic fiber travels and see it is synapsing in the ciliary ganglion. Now, the postganglionic nerve that comes out, that nerve is the short ciliary nerve, and this short ciliary nerve, see, it is supplying two muscles. One, it is supplying the constrictor or the sphincter pupillae, and it is supplying the ciliaris muscle. So, this is about the distribution. So, when you write it, how do you write it? You will write that the distribution, the branches, the main trunk of the oculomotor nerve does not give any branches. So, it gives off two rami, one is the superior ramus, another is the inferior ramus. The superior ramus gives off two branches, one is to the superior rectus muscle and another is the levator palpebrae superioris. The inferior ramus gives off three branches, one is the nerve to medial rectus, next is the nerve to inferior rectus, and finally a very important branch, that is the nerve to inferior oblique, because till now what I have described, that is the somatic efferent component of the oculomotor nerve, but the general visceral efferent component will also accompany this inferior oblique nerve, and it then relays into the ciliary ganglion, while the postganglionic fiber from the ciliary ganglion forms the short ciliary nerve. There are about 8 to 10 of these nerves, and these nerves will supply two muscles, one is the sphincter pupillae and another is the ciliaris. So, this is about the distribution, how you write. Now, coming to the last part of our video, that is the clinical anatomy, that is what is important. Now, this oculomotor nerve can be affected by some vascular lesion in the midbrain. So, we know that since this part of the midbrain is supplied by the posterior cerebral artery. So, if there is an occlusion of this posterior cerebral artery, it will affect the oculomotor nerve, and there are two syndromes that occur, which we will discuss also when we are doing the brain videos. There are two syndromes, one is the Weber syndrome and another is the Benedict syndrome. Now, the symptoms or the signs produced by these two syndromes are different because of the different type of structure affected. In Weber syndrome, which is a vascular lesion of this posterior cerebral artery, two structures are affected, and this is the region, this marked in yellow that you can see, this is the area where Weber syndrome affects. So, see, it is affecting what? It is affecting the crus cerebri and it is affecting the third nerve. So, with relation to the third nerve, we will have the same sided third nerve palsy in the form of loss of movements of the extraocular muscles that I will describe a little later. So, there is ipsilateral, that is same sided third nerve palsy. Now, what happens when this crus cerebri is also affected in case of Weber syndrome? Through this crus cerebri passes the corticospinal tract or the pyramidal tract, which is responsible for the movement of the opposite side of the body. Okay. So, if there is a Weber syndrome, there is the same sided third nerve palsy and whatever signs and symptoms that we have because of that, and we have the loss of movement of the opposite half of the body, which is known as hemiplegia. So, plegia means paralysis, hemi means half, so that means half of the body cannot move. And which half? If it is a lesion on the right side, so the left sided half of the body, there is loss of movement. So, that is called contralateral hemiplegia. So, in your theory question, it will come in this manner, that a patient presents with ipsilateral third nerve palsy and contralateral hemiplegia. So, what is this syndrome? You have to explain. So, this you have to say that this is the Weber syndrome, which happens when the third nerve is affected at the level of this superior colliculus of the midbrain due to vascular lesion of the posterior cerebral artery. Now, if the red nuclei and lateral to that this blue structure that you can see, this is known as the medial lemniscus, this is affected. So, this can be also affected along with the third nerve in a separate syndrome, and that is known as the Benedict syndrome. So, in Benedict syndrome, apart from third nerve, two more structures are affected. One is the red nucleus, another is the medial lemniscus. Now, what happens in that? In this, the red nucleus is responsible for the fine movements of your body. So, there is tremor and other features, and medial lemniscus is responsible for the contralateral deep senses, as in touch, pressure, position, vibration senses and all this. So, in this people with Benedict syndrome, the symptoms would be ipsilateral third nerve palsy and contralateral loss of touch, pain, touch, position, vibration senses, as well as there is presence of tremor and other abnormal movements. So, this will be dealt with in the brain lectures. So, we have to now specify in this lecture about how will you detect a person having a third nerve palsy. So, what is the effect of lesion of a third nerve? So, here in this picture I have already depicted, we have discussed about the distribution of the third nerve. So, we said that the superior ramus supply the levator palpebrae superioris muscle, and this levator palpebrae superioris muscle, name is levator, that means it will elevate, palpebra means the lid, superioris means the upper lid. So, the function of this levator palpebrae superioris is it elevates the upper lid. So, that you are opening your eyes, that is because of the levator palpebrae superioris. So, if the third nerve is paralyzed, then you close the eye because another muscle which is called the orbicularis oculi, which is supplied by the seventh nerve. So, what happens is that when you ask the person to open his eye, he is not able to open his eyes completely. So, that condition is called ptosis or the drooping of the upper eyelid. So, there is drooping of upper eyelid. So, drooping of upper eyelid is the common term that we use, and ptosis means there is, it is the anatomical term that we use or clinical term that we will use here. Next muscle that is very important by which we can understand is that we said 3 LR6 SO4, that means LR6, that is lateral rectus, is supplied by the abducent nerve, but medial rectus, which is the opposite muscle, that is supplied by the inferior rami of the third nerve. So, if in case of oculomotor nerve palsy, the medial rectus will not function. So, as a rule, if one group of muscle is paralyzed, the opposite group takes an upper hand. So, the lateral rectus will pull your eye. When you ask the person to look medially, the lateral rectus will pull that particular eye on the lateral side. So, it gives rise to a lateral squint. So, your lateral rectus pulls the eye. So, this lateral squint is because of the LR, which is supplied by the sixth nerve. Now, next feature, we said that the branch to inferior oblique through the ciliary ganglion and the short ciliary nerve, it supplies two muscles. One is the sphincter pupillae. So, the name only suggests it will help in constriction of the pupil. So, in case of third nerve palsy, the constriction of pupil will not take place. So, what happens? The dilators of the pupillae, which is known as the dilator pupillae, which is supplied by the sympathetic nerve. So, the sympathetic nerves supply the dilator pupillae. This dilator pupillae will dilate the pupil. Second feature that happens here is the ciliaris muscle is paralyzed here because of the third nerve, and this ciliaris muscle, I said, is helping in the changing the convexity of the lens, thereby helping in accommodation. That is, when you are looking from distant to a near vision. So, from distant vision, when you are trying to focus something near, your pupil or the lens needs to become more convex, and that is done by the ciliaris muscle. So, if the ciliaris muscle does not function, so there is a loss of accommodation. So, when you are asked in your theory exam that a patient of Weber's syndrome presents with ptosis, lateral squint, dilated pupil with loss of accommodation with contralateral hemiplegia, you will be asked to explain. So, this is how you explain that You just by writing third nerve palsy will not suffice. So, you have to write exactly what is the reason for these clinical signs that you have to look for in a patient of third nerve. So, with this we come to the end of this video. Happy learning. Thank you.